Good afternoon, everyone. It's my really a great honor to be here to share some of our research findings, and I would like to thank again the Kyoto for organizing this very interesting and fruitful event. So I myself is an infectious disease epidemiologist with a special interest in TB, tuberculosis. So I'm going to share a story about the introduction of a new diagnostic tool of TB to the world. So TB is still a major infectious disease globally. So last year there were more than 10 million incident cases of TB with the death toll of about 1.4 million, plus another 0.4 million among HIV positive patients. And you can see that among the leading causes of death globally, TB is very top on the list. And the number of deaths from TB is even more than the number of deaths from HIV now. And even if we just count the deaths from TB among HIV positive patients as HIV deaths, TB is still number one. Therefore, the WHO has set up a goal to control and eliminate TB by 2035. And in order to achieve that goal, it is expected that more than 90% reduction in TB incidence has to be achieved. But if you look at the current trajectory, we're still very far from this goal. Therefore, innovations and new tools are certainly needed, including the UHC. So just very briefly about the natural history of TB. Uninfected people, once they get contact with infectious patients, they may get latent infection, and about 10 to 15% of those with latent infection may develop active disease with symptoms and can transmit to other people. Those without treatment, those active disease without treatment has almost 50% mortality. On the other hand, with proper diagnosis and treatment, we can more than 95% of the cases can be cured. Therefore, the principle in terms of the control of TB is actually the diagnosis and treatment of active cases of TB. This will do good to the patients with active TB, but this will also have an indirect effect in terms of transmission, because we know that the transmission of TB depends on those with active TB. So we talked a lot about prevention of NCD yesterday, but in terms of infectious diseases, a proper diagnosis and treatment is actually a key measure for prevention as well as for cure. However, neither the diagnosis nor the treatment for TB is easy. So this is a global situation in terms of TB case detection. So on the upper part of the graphs, the green bands is the estimated incidence of TB globally, and this black line here is the actual TB case notification. And you can see there's a large gap in almost all regions of the world, suggesting that TB case detection is not optimal. And one of the key reasons for this suboptimal case detection is that we're still using very old tool for TB diagnosis. So in many developing countries, they are still using sputum microscope for the exam of TB. And we know that sputum microscope exam has a sensitivity of around 50%, for 50 to 60%. That we're missing a lot of patients if we just use the sputum microscope. And the proportion of missing will be even higher if you use the test among HIV positive patients. So in the past several years, there has been a very new excitement about introducing new tools. So one of the star among these is the Xpert MTB RIF. It's an automated PCR-based test, and the test will give you the results within 2 hours. And also, it has a much better performance in terms of sensitivity. So even among those who are smear negative under microscope, the new test can detect more than 70% of these cases. So therefore, not surprisingly, after the new tool is on the market, the purchase of both the machine and the cartridge has increased almost exponentially in the past several years. And there are a number of studies about the accuracy of the test. So the evidence from systematic reviews about the accuracy, sensitivity, specificity shows that the test is actually doing a good job. So this is a review on adult patients and a review on extrapulmonary TB and the review from in children. They all suggested that this new tool has this great potential. Therefore, the WHO has suggested the use of the new tool, especially in high HIV or high drug-resistant TB settings, but also in other settings. So what is going to happen if we just use this tool very widely? I call this optimistic view about this. What's going to happen from the WHO recommendation is that this widespread introduction of the new tool is going to allow TB patients to be diagnosed early and accurately. And this will lead to less advanced forms of TB being diagnosed. Treatment delays will be reduced, and disease transmission will decrease. However, this is most of these arguments is based on the improved accuracy and a number of assumptions that are not well described. So if you think more carefully about the diagnostic pathway of the TB patients, they often need to go through a very long and I would say very lonely journey before they are being diagnosed. So you can see that patients after being sick have to wait often for a period of time before they go to the healthcare clinic and becoming a suspect and receiving a number of tests. So they have to go through this circle before they are finally diagnosed. And even after the diagnosis, they need to go back to the clinic for the medicine and for the re-examination before they are finally cured. So this long journey from the start point to the point of cure often takes months or even years. 2 to 3 years is not uncommon. So during this long process, you can imagine that there are multiple exit points for the patients, so that they might default from this process anytime for various reasons. So we think that a more comprehensive view of the new diagnostic tool is to consider this whole process from being sick, healthcare visits, being diagnosed, completing treatment, etc. Along this whole process, the new diagnosis tool only is a crucial step, but it's only one step among these many steps that are required for completion of the treatment. So we proposed, at the time of the introduction, we proposed an approach that we called virtual implementation. So this is a project funded by the US aid to the International Union Against TB and Lung Disease. So under this project, there are 2 modeling teams, one team from the Liverpool School of Tropical Medicine, and the other is us from National Taiwan University. So we collaborated with our partners from Tanzania, National TB and Leprosy Program, to see and project the potential impact of the new tool on TB. So one of the unresolved questions for this is, how would the new test affect the transmission and epidemiology of TB? So in order to answer that question, we use a disease modeling approach. So briefly, we separated the population into different subgroups of people based on their disease status. And the transition between these states, they are described usually by differential equations. And the very key step in this is that the step of transmission from susceptible to infection will be affected by the number of prevalent infectious cases. So using this modeling approach, we will then be able to model the impact if we introduce a new tool and decrease the number of prevalence cases, and that will have a secondary effect in terms of transmission. And because we wanted to understand the impact in the whole context of the new diagnostic tool, so we further expand the infectious disease states into several different states to include the state of being sick and then the state of going to the healthcare center and then receiving the primary diagnostic tool or the test negative, the secondary diagnostic tool. So using this model, we'll then be able to project what would be the potential likely impact if we replace the primary diagnostic tool with the new tool called Xpert. So this is our primary finding in terms of the impact of the new tool on the incidence of TB. So compared to the old tool, the sputum microscope, we found that the new tool, Xpert, will have actually a very limited impact on incidence. That was a bit of surprise to us initially, but after a careful thought about this whole process, we found that it probably makes sense. So one of the reason of the limited impact of new tool is that the additionality of the new tool is that it will identify mostly the smear negative cases compared to the traditional tools. And we all know that the smear negative cases, although they are important, but they tend to be much less transmissible compared with smear positive cases. So usually they're about 1/5 in terms of transmissibility. And secondly, in many developing or resource constrained settings, there is often a very long pre-diagnostic delay. In other words, the transmission of the disease often happens before the patients got diagnosed. So therefore, even if you improve the diagnosis of TB using the new test, what happened before they go to the healthcare setting, and the transmission is already there. So therefore, that's why we found a very limited impact on incidence. So in order to better understand the full impact of these contextual factors, we performed a formal univariable sensitivity analysis just to understand what contextual factors would have an impact on the performance of the new diagnostic tools. So for example, if the patient delay is longer, then you can see that the impact on TB incidence will be much reduced. And also, if the tool is used as a primary tool, and that would also depend on the sensitivity of the secondary diagnostics. So in many resource-constrained settings, the secondary diagnostics is often an empirical treatment by antibiotics or chest X-ray. So it's essentially the empirical treatment based on the physician. And it's not common in many restrained settings that the physicians will treat the patients anyway, even if they are smear negative. So if the sensitivity or the empirical treatment proportion is high, then we would expect that the impact of the new tool will be less. And also, in many places, a lot of patients, even after diagnosis, they got defaults before they even start their treatment. That's what we call initial defaults. So I think the take-home message is that the impact of the new tool with very high sensitivity is not a fixed number. It depends on where and how you use the new tool. And we found that there are a number of contextual factors that can affect the performance or the impact of the new tool. And unfortunately, we actually do not know very well about many of these factors in many settings. So one of my graduate students, my doctoral students, Elias O'Neill, he's a doctor, he's a physician from Cameroon. He recently completed a survey in Cameroon about the initial default, the default after diagnosis before treatment. And he found that more than 10% of the smear-positive TB patients in Cameroon actually did not start any TB treatment. So no treatment, no effect on diagnosis. So question number 2 that we try to address is to identify the optimal policy options in terms of selection of the new tool for a specific country setting. So this is a graph from the WHO. So each of these blue dots are the new test that was endorsed and recommended by the WHO. So you can see that every year there were some new tests coming, and more new tests are to come. So the challenge to the policymakers is which one to use among these many new tests. And the second question is, how should they use the test? Do they use the test as a primary tool to replace the microscope? Or if it's too expensive, like Xpert, should they use it until the test negative for the primary tool and use it as a backup or secondary test? And lastly, there are multiple layers of outcome that needs to be considered when we talk about the impact of the new tool. So for the new tool like GeneXpert, there might be it may have some impact on the healthcare system. For example, the staff requirements will be different because it's an automatic machine, and the healthcare capacity or the investments, whether you want to invest because it's a lot of money to invest in a new machine, And also, we just talked about the new test might have some impact on the epidemiology of the TB. And what's even more complicated is that these kind of different layers of effects may have some interaction. So I just talked about that these different contextual factors on the healthcare system might affect the performance of the test in terms of epidemiology. But on the other hand, the impact on epidemiology, for example, the number of incident TB cases, can secondarily affect the impact on healthcare system. For example, the number of TB patients that visit the healthcare facility in terms of the capacity. So we proposed a joint modeling approach to address this issue. So in this approach, we work with our Tanzania partners to look at the number of diagnostic options that were considered by the Tanzania NTP. So the conventional microscope, or the new type of LED-based microscope, or they used the microscope and collected the sputum samples on the same day instead of the separate days, or the use of the new test, the Xpert, either as the initial test or as the secondary test. So we wanted to see what would the impact of these different diagnostic options, both in terms of healthcare system and in terms of the TB epidemiology. So the approach we use is to combine two different modeling approach. One is the disease modeling on TB dynamic, just like the one I just introduced. And the other one is the operational modeling that address the impact on the healthcare system. And so we do this modeling in a way that the output from the operational modeling can be an input. For example, the staffing, the default rate can be an input to the epidemiological model. And the output from the epidemiological model, for example, the TB incidence, can be an input for the operational model. So these two models are linked dynamically. So just a bit more about the operational modeling. The operational modeling was done by Ivor Langley from Liverpool School of Tropical Medicine. So before coming to Liverpool School of Tropical Medicine, Ivor is actually a general manager in a large retailing chain store called Argos. I'm sure those from the UK know what is Argos. So his main job is actually looking at the stockpiles of the goods in the retailing company. So, but he applied this kind of technique to TB patients and TB samples. So he treated the patients and the samples as goods, like a stock flow, and tried and using the healthcare system in Tanzania to project the potential impact of the new tool in terms of the costing and in the whole healthcare system. So once we combine the epidemiological model and the operational model, we will then be able to see the impact of the new tool under different options, both in terms of the TB incidence and death, and we can use that to calculate the deaths averted, and also in terms of the costing based on the operational modeling. So we can plot that and use this to conduct a cost effectiveness analysis, and we can see that the full implementation of the Xpert will generate the most benefits in terms of the deaths, averted, but it's also most costly. But overall, we found that the most cost-effective ones is the use of LED, but even the options of the Xpert for every new suspects, the ICER is 169, which is below the generic threshold of the GDP, which was about $600 in the case of Tanzania. On the other hand, the cost effectiveness does not necessarily imply sustainability. So if we plot these different options by the average cost effectiveness ratio against the expected incremental increase in terms of health budget, we can see that although the Xpert full rollout is considered cost effective, but it's actually costing a lot of money to the healthcare system. So the overall projected budget to the Tanzania TB program is about 25% of the whole TB budget. So at the time of the analysis, it was not considered possible to really full out at the country national level. So I just talked bit about the modeling ones, but now we're going back to the sort of the real life. So in Tanzania, we met regularly to our partners at NTOP, and to present our results and suggestions. And we also had some field visits to see what's happening in the field. So this is in Kitamboko, one of the large diagnostic centers. And at the time of our visits, it has just introduced a new tool, the Gene Xpert. So we were very interested to know their experience with the new tool, but we were surprised then to find that the new tool were actually out of use for several months at the time of our visits. And the reason is that the new tool requires an uninterrupted power supply. And it's actually very common, even in this large center, to have power shortage 2 times or 3 times every day. So all this kind of new machine was equipped with a UPS, uninterrupted power supply. But it was unfortunate that this UPS was broken, and they had to wait for the maintenance for several months to come. Okay, so the real life setting, so it suggested that our modeling result might be a bit more optimistic. In the real life setting, the impact might be even more limited. Another, even maybe more disappointing answer from South Africa is from the recently published study called Extent. So in South Africa, they have adopted the WHO recommendation fully. So starting several years ago, they decided to replace the sputum microscope with the new test of Xpert at the national scale. So they did this through a step-wedged process. So at the same time, there's a large cluster randomized trial that was done to evaluate the impact of this new tool on TB mortality at 6 months. And the quick answer is that if you look at the adjusted risk ratio of death, which is almost 1. So if they compare the healthcare centers that implemented the new tool to the centers that didn't implement the new tool, and they found there's no difference in terms of mortality. And why is that? The most possible explanation is that we can think about this process. The most possible explanation is that many of these patients, they are very sick, so there was a long patient delay before they actually went to the healthcare settings for diagnosis. And also, in terms of the diagnostic process, the empirical treatment for suspicious TB patients in South Africa is very high. So that means that the patients will receive treatment, whatever. So whether the test result is positive or negative. Therefore, this new additional tool has just a very limited impact. So it seems like a no-brainer, but it took us several years to actually fully appreciate the importance of the infrastructure of the healthcare system and the efficiency. So I think the take-home message for my presentation is that if you throw a very new, very good machine to a setting that has very poor infrastructure, then you don't expect to see a very large impact. And it has to do with the efficiency of the healthcare system and also the access to care when they become sick or even after they become diagnosis. So this come back to our theme, which is the UHC. I think that would be one of the key issues to be addressed before we talk about any new innovations, specific innovations. So with that, I'll stop my talk and like to answer any questions. Thank you.